Thanks so much. So as everyone, I think, realizes at this time, the real truth about health is that it's out of date. And this old idea of prescriptive pad medicine, which is what I was taught in medical school back in the 70s, is no longer applicable and no longer helpful for these very complex illnesses. And as we were just hearing, things like mercury, huge issue, and we really need to look at these and look at organismal health. So let me share some slides here and go through a couple of things and talk a little bit about what we've been doing with our latest trial. And let me share that. Okay, and let's pull this up. Here we go. There we go. Okay. So the whole idea of network medicine is that we need to quit thinking about human beings as being simple, come in for 7 minutes and you get a prescription that has absolutely nothing to do with what's causing the problem. 100 years ago, of course, most people were dying from simple illnesses, things like pneumococcal pneumonia. And on the other hand, today, virtually all of us are dying from complex chronic illnesses. And I see there are about almost 200 people here. So that means about 30 of us here today will die of Alzheimer's disease. And the challenge today is, let's see if we can make that zero. Let me show you how this disease works. Let's look under the hood. We spent 30 years, published over 220 peer-reviewed papers on understanding what actually drives cognitive decline in Alzheimer's disease so that we could fashion the first effective treatments. And we've had unprecedented success in preventing and reversing cognitive decline. And as you might imagine, the sooner you start, the better off, the easier it is, and the more complete return that you get. Okay, so there we go. All right, so I want to just mention before we get started here the semantics of success, because a lot of us have heard about a successful drug, and there's been a lot of argument, a lot of controversy. And as you may have heard, when the FDA approved this drug right here, which is called aducanumab, which was back in June, 3 of the expert panel members, there are 11 expert panel members, all of them were not enthusiastic. In fact, all of them said, do not approve this. The FDA decided to approve it anyway. And we could understand to some extent they were saying, well, hey, we haven't had anything in many years. Maybe this is something. The problem, as you can see here, is that the very best this drug did was not to make people better. It was not to stabilize cognitive decline. But in fact, it was in one trial at one dose only to slow the decline here by 22%. So you can see if you have Alzheimer's or pre-Alzheimer's, MCI, which is mild cognitive impairment, then on average you lose about 3.5 points on a 30-point scale, MoCA, MMSE, things like that. You lose about 3.5 points per year. With aducanumab, again, one trial failed completely. Another trial failed on certain doses, but on one dose, it improved by 22%. It just slowed the decline. Now, in contrast, the trial that I'll show you today, and it's now been accepted for publication, it's already online so that you can see the preprint on medRxiv already. We actually saw people improve their performance. And as I'll show you, people who improve their performance sustain their improvement. And this is because we're not trying to treat this as a simple illness and give one prescription, the same thing for everybody. We're flipping the script and we're saying, what are the things that actually contributed in each of these people? And then we are attacking those things. All right, so I want to show you a specific example. So here's a 68-year-old woman, one of the many people who's come, and we have thousands of people now who have been on this protocol. As was mentioned earlier, we had the first 10 came out in 2014. We published another 10 in 2016, and then we published 100 in 2018, and then we published our trial last year, and we're now starting a larger trial. So this woman actually started with paraphasic errors. So she was saying the wrong thing. She was saying the wrong words. And of course, we've just all heard that Bruce Willis has aphasia. So she presented in somewhat similar fashion. And then she had depression as well, which again is relatively common in people who have a specific subtype of Alzheimer's that I'll talk about in just a moment, which in this case turns out to be the toxic type. So as many people do, she struggled with her computer work. She couldn't finish a gingerbread man that she had done many times before. She had trouble with clock hands, and that's a relatively common problem. It typically means that you have parietal lobe dysfunction. And then finally, she started having memory problems, forgot to pick up her granddaughters, which really worried her. And so she actually had what we would call a non-amnestic presentation. About 2/3 of people, as they are developing Alzheimer's, have an amnestic presentation, so they struggle with memory. But about 1/3 of them, including this woman, will have a non-amnestic presentation, problems with executive function, with organizing things, problem with things like recognizing clock hands, recognizing shapes, calculation problems, word finding problems, all of these sorts of things. She then had an amyloid PET scan. So she went in for a classical evaluation, had an amyloid PET scan that was positive, indicating that she was on her way to developing Alzheimer's disease. She was ApoE4 positive, so she had the most common risk factor for Alzheimer's. And we'll get into why this is such an important risk factor. So if you look at the United States as a whole, then about 3/4 of us are ApoE4 negative. And so that means that we have about a 9% chance during our lifetime. Now, it's not zero, but it's not terribly high. If you have a single copy, which is what this woman had, that's 75 million Americans, and the vast majority of them don't know it. Their risk is about 30% during their lifetime. And if you have 2 copies, so in other words, one from your mother and one from your father, then your risk is substantially higher, well over 50%, and that's 7 million Americans. So the reality is we should all know our ApoE status. And yet, the Alzheimer's Association says, no, don't bother to check this because there's nothing you can do about it. As I'll show you, nothing could be further from the truth. Now, her MoCA score, perfect score is 30, and hers was already, if you drop below 28, you're already beginning to show mild cognitive impairment. If you're down at below 22, you have full-on Alzheimer's disease. Hers was 24, so she had quite significant MCI, and she happened to be a highly intelligent professor, so she was likely to be falling relatively late in her overall time, her overall process. Her hippocampal volume was already down to the 14th percentile, and many people who are developing Alzheimer's or who have Alzheimer's will have a reduced hippocampal volume. So you actually get shrinkage in that part of your brain, which is critical for memory. So as I say, her diagnosis was mild cognitive impairment, and it's unfortunate that the term mild is used. It's a little bit like saying to someone, don't worry, you only have mildly metastatic cancer, because it's a relatively late stage of cognitive decline. So she began on a clinical trial with an anti-amyloid drug, just like the one that I just showed you. And with each injection, she actually got much worse. And this has happened to a number of people, and I'll show you why. So after 8 treatments, she said, this is not working for me. It's making me worse each time. And then she would kind of slowly fight her way almost back to where she started. Then she'd get ejected again and get worse again. So fortunately, after 8 treatments, she left the trial and she ended up emailing me. So she, and further evaluation, failed her visual contrast sensitivity. Her C4A was high, 7990, shouldn't be over 2830, as Dr. Shoemaker has taught us. Her TGF beta 1 was high, her MMP9 was high, her urinary mycotoxins were high, a number of them, such as ochratoxin A, for example. Her Marcons was positive. Her HSCRP was a little not off the charts, but again, this is very common with mycotoxin-associated illness, that you have some degree of inflammation, but your HSCRP isn't off the charts. But hers was slightly high. And then interestingly, many of these people who have mycotoxin-associated cognitive decline, for reasons that we don't understand yet, have very low triglycerides, and this may be partly from malabsorption. Her triglycerides very low, 29, and her zinc also low, 2 things that we often see in people who have mycotoxin-associated cognitive decline. So she began on the protocol that I'll show you today, which is personalized. So again, we looked at all the different things that are contributing to her, identified those, and almost nobody has one cause of cognitive decline. Most people have a combination. They may have some insulin resistance. They may have some leaky gut. They may have exposure to specific toxins, as we've heard about here. They may have other things as well, and may have poor dentition with an abnormal oral microbiome. So she was started on a protocol that addressed all these things and included some basics like a plant-rich, mildly ketogenic diet. We call it KetoFlex 12-3. Her Marcon's treatment, detoxification, among other things. Actually going after what was causing the problem instead of just trying to remove the amyloid, which is actually there as a protectant. It's part of your innate immune system. Her symptoms resolved. She was once again able to speak, cook, shop, tell time, build gingerbread men, no longer forgot to pick up her granddaughters. And that was 6 years ago. She's now 6 years into this and still scoring a perfect 30 on her MoCA. So her MoCA went from 24 up to perfect 30, and it stayed there. Her hippocampal volume improved from the 14th percentile to the 28th percentile. She's remained stable, as I mentioned, for 6 years. So the features that we have to think of when we think of this particular presentation, and I mention it first because it's a relatively common one, and it's one that people find in general is the hardest to deal with because you do have to address these various issues. And it's very common for people to have mycotoxin-associated cognitive decline. So when you should especially think about this if you're seeing patients is if someone comes in, it won't all be like this, but if someone comes in and it's an early onset, 45 to 60. Now, this woman actually began her first symptoms way earlier, early 50s, but I did not hear about her until she was in her late 60s, as I mentioned. So often associated with perimenopause or menopause. The non-amnestic presentation that I mentioned earlier, when you see that, often with executive dysfunction and or dyscalculia, then it really should make you think about mycotoxin or other toxin-associated cognitive decline. And I should mention, if they also have an amnestic component, which she did when she forgot to pick up her granddaughters, they're often ApoE4 positive, which she was. If they're ApoE4 negative, however, this is a common reason to have cognitive decline. The ApoE4 negatives don't have as often the risk for things like cognitive decline associated with inflammation or with insulin resistance. They relatively commonly have problems associated with insulin resistance, associated with mycotoxins, or tick-borne illness is another common one. If it's accompanied by depression, of course, most people who develop Alzheimer's, it's not associated with depression early on, at least. This woman clearly had some depression. And again, that triggered us to think, okay, this may be a mycotoxin-associated contributor. If they have low serum zinc, if they have low triglycerides, and she had both. Low glutathione, also common, and of course, BCS failure. Now, interestingly, some of these will have SIRS-related symptoms, as Dr. Shoemaker described years ago, chronic inflammatory response syndrome. But interestingly, as he pointed out to me, most of the people that we see and the ones that we've reported haven't met the criteria for SIRS. So they don't have the ice pick pains, and they don't have the electric shocks, and they don't have the lung problems, and they don't have the rashes and things like that. However, about a third of them do. One of the other features, they are hypersensitive to stress, probably because they have HPA axis dysfunction. But for whatever reason, what we hear frequently is this person was going along, and for example, one of the ones was from a law practice. He had the toughest case of his life, spent 2 years up all night, all the time, won the case, and then completely crumped. We hear this all the time. And the other common thing is someone will get better, and then they will start going on overnight flights, or they will take on a new job or that sort of thing, and they'll go downhill again. So this woman, part of her doing so well is she has made sure that she doesn't have a tremendous amount of stress. So these people tend to be hypersensitive to stress. And then if they have headache, and or sinusitis. That's another tip-off that this may be mycotoxin-related illness. So if you think about it, this really is a pandemic without a vaccine. And I'll show you why here. So for perspective, COVID-19 has actually now killed over 1 million Americans. And for comparison, of the currently living Americans, about 330 million Americans, about 45 million of us will die. So we're still at over 45 times the number. So it's a pandemic that actually dwarfs the COVID-19 pandemic. And here's why. With COVID-19, it's a relatively simple illness. We know it's a virus. We have sequence of the virus. We have sequence of the variants. We know what Omicron, Delta, all these different things are. With Alzheimer's, that has not been the case. We don't have an agreement on what this actually is. And so therefore, people have the idea that it's type 3 diabetes, or that it's herpes simplex, or that it's a prion, or that it's amyloid, or that it's tau, and on and on and on. But there's not agreement. In fact, none of those ideas has ever led to significant treatment. So we need to understand the fundamental nature of Alzheimer's, which is what our research has been about for the last 30 years. And there are over 150,000 papers from all over the world that have been published on this disease. And so pretty much any idea that you come up with, you can pretty much rule it out just by looking at the papers. We need something that will actually tell us what to do. So as I mentioned a couple of minutes ago, there's a problem here, which is that there's a term mild cognitive impairment, which is used every day by doctors. And unfortunately, it's a relatively late stage of the Alzheimer's pathophysiology. So you begin the pathophysiology about 20 years before a diagnosis of Alzheimer's. And MCI is the third of 4 stages. And what happens is doctors will say, don't worry, it's just mild. It's mild cognitive impairment. And the person goes home, don't worry. They told me don't worry, it's just mild cognitive impairment. No, that actually should be called advanced stage Alzheimer's disease because it is the second to the last stage of this disease. Phase 1 is you're asymptomatic. You don't have symptoms at the beginning, and you can already show changes. And this is for many people in their 30s and 40s. So the disease that when I was training in neurology, we thought of as a disease of your 60s, 70s, 80s, 90s, is really a disease of your 30s, 40s, 50s, 60s, which gets diagnosed 20 to 25 years later. So in the first phase, you're asymptomatic, but your spinal fluid will show abnormalities. Your PET scan will show abnormalities even at the beginning. Then phase 2 is subjective cognitive impairment. You know there's something wrong. Often your spouse will know that there's something wrong. Perhaps your coworkers will know there's something wrong. But if you take a formal test, you'll still be scoring in the normal range. So that's called subjective cognitive impairment. And the reality is everybody should know it. So this is why it's so critical. Get in. People will tell you, it's just normal aging. No, normal aging should not be accompanied by problems with memory and problems with drawing a clock and problems with these sorts of things. Now, SCI lasts about 10 years. This is what the epidemiologists have shown. This is huge because it tells us we have an amazing window to reverse this. Virtually everybody with SCI can be reversed and return to normal function. But the problem is that people wait and wait and wait until they're in late stage of Alzheimer's. Again, cognitive symptoms without abnormal cognitive testing. Now, if you don't do anything about this, you typically will progress over those 10 years into MCI, which, as you can see, is really the third phase of a 4-phase illness. We call it MCI, and by definition now, you do have abnormal cognitive testing, but you're still having normal activities of daily living. When you begin to do activities of daily living begin to be a challenge, that's when you have full-on dementia, in this case due to Alzheimer's disease. 5 to 10% of people with MCI will convert to full dementia each year. And then the final phase is Alzheimer's disease. And again, this should really be called final phase. And this is where your activities of daily living are affected. So you can see the problem here is we focus, and everyone has focused on understanding and treating Alzheimer's disease. This is like saying we're not going to call it diabetes until you have ketoacidosis. It makes no sense. We want to understand pre-diabetes and even insulin resistance and what gets us there. That will give us much, much better outcomes. Now, what we've seen with the protocol we've developed is virtually everybody with SCI gets better. People who go on prevention, we haven't had a single example of people progressing to dementia. MCI, the majority, and I'll show you, we did a trial with people with MCI and Alzheimer's, the majority improved. Once you have full-on Alzheimer's, some of them improved, and we've had people go from MoCAs of 19 to perfect 30. And we've had people go from MoCAs of 0 to 9. We've not ever had a person go from a MoCA of 0, end-stage Alzheimer's, to a perfect 30. That's the goal. We want to understand what does it take to bring someone from the precipice of death, end-stage Alzheimer's, all the way to perfectly normal. It may involve stem cells, intranasal trophic factors, we don't know. Transplantation, we don't know yet. The good news is you have a very large window to in phase 1, phase 2, and even into phase 3 and sometimes phase 4 to get quite good outcomes if you simply get in there as early as possible. So as I said, the diagnosis of Alzheimer's, unfortunately, typically made about 20 years after the initial biochemical changes. And as I think pretty much everyone knows here, the problem with medicine is that we're still operating as if it's the 20th century. And in fact, standard of care medicine is still thinking it's the 20th century. I had an amazing email just a few days ago from a group in Australia. They're dealing with the national healthcare system in Australia. And the national healthcare system refuses to believe that mold and mycotoxins have anything to do with any illness. That's it. Don't confuse us with the data. They just want to ignore it and say, don't evaluate it, don't treat it, there's nothing to do, it doesn't have anything to do with health. So wait a minute, what about all these people who are having all these problems? Well, we don't know what's causing that. Well, wait a minute, what about when we treat for these problems and they get better? Yeah, that doesn't have anything to do with it. So it's amazing to me that medicine has been stuck back in the 20th century. Now, in the 20th century, we were really successful with simple illnesses. If you have pneumococcal pneumonia, yes, there's a contribution if you've got alcohol on board, if you have diabetes mellitus, if your B cells aren't performing well, for example, if you have multiple myeloma, all these things are contributors. But fortunately for physicians trying to treat it, the pneumococcus itself, the strep pneumoniae, was so much more important of a contributor than all the other contributors that we as physicians could get away with simply writing that prescription and focusing on that one problem. Now, that's great for pneumococcal pneumonia, but now we are virtually all dying of complex chronic illnesses that are fundamentally different. And so we're dying of things like cardiovascular disease and Alzheimer's disease and cancers and things like that. Now, if you look at Alzheimer's and other neurodegenerative diseases have a similar idea here, there are multiple contributors. When you come to Alzheimer's disease, insulin resistance, as I'll show you in just a moment, critical player here. Multiple different pathogens. The neuropathologists have shown us in the brains of patients with Alzheimer's, what do you find? You find P. gingivalis from the oral microbiome. You find Candida, you find herpes simplex, you find HHV6A, and on and on and on. So these pathogens gain access to the brain, and your brain makes the amyloid to try to kill them. It is an antimicrobial, but it is causing also downsizing of the network, very much like what we saw with our country when the pandemic came. Of course, we were all told, shelter in place, pull back, protect yourself, don't go to work. And of course, the country went into a recession. Your brain is doing the same thing. You have these various insults, you make the amyloid to fight the insults, and you're pulling back. You're saying, I can't maintain these 500 trillion synapses that a human brain has, but I'm going to fight them and go into a protective downsizing mode. And unfortunately, if we don't identify the insults, You just keep downsizing, downsizing, downsizing until you die of Alzheimer's disease. So pathogens, critical, NF-kappa B, anything that is inflammation related. Mercury, another critical contributor. Mycotoxins, as I just showed you with that patient. Organic toxins, homocysteine, so methylation issues, detox issues, on and on and on. And there are many more of these. The problem, as you can see here, is there's not one single one that you just say, oh, I write a prescription for that one thing and it's gone. It's not a simple illness. It's a network dysfunction, which is why we need to take a network sort of approach, or functional medicine or precision medicine sort of approach, identifying and treating. Therefore, this is the area of greatest biomedical therapeutic failure. You look at drug after drug after drug after drug. And I think the 11 on the expert FDA panel would all argue, as they did, that in fact aducanumab should not have been approved because it is not an effective drug. And unfortunately, it has multiple side effects, microhemorrhages in the brain, cerebral edema in 40% of people, and unfortunately death in one of the recent patients. So here's the problem. The current standard of care has not kept up with the research. So when you go into a memory center today and you say, I'm having cognitive problems, the doctor will tell you, well, you have Alzheimer's disease. Well, there's a cause. We don't know what the cause is. It's one disease. It's called Alzheimer's. And there's one treatment. We're going to give you a prescription for Aricept or aducanumab or something like this. It's a monophasic approach, and it's ineffective. You're going to die of Alzheimer's disease, and we're not going to look for the things that are actually driving this. That is a horribly, horribly out-of-date approach, but it's what's being practiced virtually everywhere. The research findings show something completely different. There are dozens of contributors, and initially we identified 36. We now know of a couple of more, but I just showed you some of them, things like mycotoxins and things like organic toxins and things like insulin resistance and things like that. Therefore, there are 6 different subtypes, and we'll go through those in just a second. And no surprise then, there are many personalized programs. We have to determine for each person why they have cognitive decline or why they are at risk for cognitive decline. And I hope that virtually everyone who's 45 years of age or older will get on active prevention, because we could have a dramatic reduction in Alzheimer's disease if people would actually get on active prevention. So let's look under the hood here. Let's look at what actually causes this disease. And so here's a schematic. You can see this amyloid precursor protein right here, which is a type 1 membrane receptor, amino terminus out here, carboxy terminus in here. Here's the cell membrane. This is in your neurons, especially near your synapses, and to a lesser extent in other cells. Now, this thing is a really interesting switch. When things are good, when you have not a lot of inflammation, when you've got plenty of trophic support, hormones are optimized, nutrients are optimized, things are good, your brain says, I'm not under attack, things are good, I can build and maintain, very much like a country. So you can think of this as my brainistan. Here's your country, things are good, you're going to grow and interact. And so APP is a master switch for this. When things are good, it gets cut at a single site, and it produces these 2 peptides, SAPP alpha and CTF alpha, and these support the idea of making and keeping new synapses. So literally making and keeping memories. And you can trace the molecular pathways to this. As an example, estradiol, one of many examples. Estradiol binds to estrogen receptors, of course, enters the nucleus, affects hundreds of genes, and among those genes is the protease, the alpha secretase, that cuts right there. So you can see that estradiol, getting an optimal level, helps you to get onto this side, which is the synaptoblastic side, making new synapses. On the other hand, when things are bad, you've reduced the support. Blood flow has gone down because of vascular disease. Oxygenation has gone down because of sleep apnea or upper airway resistance syndrome. Your mitochondrial function has declined. Your nutrients are low. Inflammation has made a higher demand on this. This is very much a supply-demand issue. Then you go into a protective mode. where you have oral microbiome getting into your brain. Then it cuts at 3 sites. And the reason it does that is because this is now a protective downsizing mode. This amyloid that has been vilified in Alzheimer's, and for which the drug companies have tried to develop drugs to remove it, as we saw with that patient I presented earlier, they tried to remove the amyloid, she got worse. No surprise. This was her response to these ongoing insults. And so, in fact, the amyloid, the A beta peptide itself, is part of the innate immune system. So very much like, again, what's happened with the pandemic, people died of cytokine storm. In Alzheimer's disease, people are dying of cytokine drizzle. You again have a mismatch where your innate system is activated, A beta being part of that. And it's not like cytokine storm, but it's like cytokine drizzle. And unfortunately, your adaptive system hasn't kept up. You continue to have the insult. And so you keep that innate system on. You keep making that amyloid. You keep downsizing over time. We need to figure out what's causing that, reduce the inflammation, get the adaptive system working appropriately, optimize things, and allow these people to go back to the synaptoclastic side and away from the synaptoblastic side. So your brain then responds by making these 4 peptides that tell your brain, go into a protective downsizing mode. So what that means is that your probability of developing Alzheimer's is proportional to an integral over time of all the things that are causing your synaptoclastic signaling. That's the ones that are pulling back, over all the things that are causing the synaptoblastic signals. Now, that doesn't tell you what test to order. The good news is it's really 4 major groups of things that you can test. And the good news, you can test all of them and you can address all of them therapeutically. And these are the 4 big groups. Anything here that causes inflammation. So that's causing a bigger drag on the supply demand. That's causing your brain to work overtime and to protect itself by making that amyloid. We want to get rid of those inflammatory mediators. And more importantly, we want to determine what's causing the inflammation so that we can remove that. And in this woman's case, of course, a lot of it turned out to be the mycotoxins she was exposed to. And then second would be other toxins, things like inorganics. Air pollution has emerged as a major contributor to cognitive decline. Heavy metals. And then organics, things like toluene, benzene, things like that. And then, as I mentioned, biotoxins, things like trichothecenes and ochratoxin A and things like that. Now, in the denominator, so things that when they're going down are a problem, energetics. And that's basically 4 things: blood flow, oxygenation, mitochondrial function, and ketones. You got to have something to burn. You got to have a substrate. And of course, we are typically we have to burn one of 2 things in our brains: glucose, ketones. And unfortunately, as we develop cognitive decline, we lose both of those. We have insulin resistance. 80 million Americans have insulin resistance, so we're not particularly good at burning glucose. And unfortunately, we're also not keto adapted. And of course, you don't generate ketones as long as your insulin is high. So we really have an energetic emergency, which is why when I see these patients, we typically want to get them started, among other things, in the overall protocol. Just take some exogenous ketones until you can develop endogenous ketosis. And Professor Stephen Kinane has shown beautifully that even ketones alone can be helpful. And interestingly, if you look at a PET scan, what do you see in a patient who is developing Alzheimer's or who has Alzheimer's? What you see is a hallmark, a signature, which is reduced glucose utilization in the temporal and parietal regions. That is the signature on an FDG PET scan for Alzheimer's. So these cells are not utilizing glucose. And what Dr. Kinane showed is that they actually can. They don't lose the ability to respond to ketones. Even though it takes a little while to be keto adapted, they can respond nicely to that. So combining those, getting these people back to insulin sensitive and back to ketosis, actually helps. So they now become metabolically flexible. They can burn both. They can go back and forth. Their brains do much, much better. So energetic reduction is a critical determinant of cognitive decline. And then the last one here is trophic support. And that's three different things. That's growth factors, NGF, BDNF, things like that. That's hormones, estradiol, testosterone, pregnenolone, progesterone, those sorts of things. And then finally, it is nutrients, vitamin D being a critical one. Again, vitamin D binds to its receptor, enters the nucleus, hundreds of genes are affected, and among them, the ability to become synaptoblastic as opposed to synaptoclastic. So those are the four main groups. Now, because of this, different people get Alzheimer's for different reasons. And that's true just like people get cancer for different reasons, different carcinogens and things like that. So you can now look to see what are the primary drivers for each person. And I should say that most people will have more than one driver, but it's important to determine these because if you can address them, this is the way you're going to get the best outcomes. So type 1 patients, they have infections, they may have leaky gut, they may have autoimmunity, other things, anything that drives inflammation contributes to cognitive decline. Then secondly, atrophic, that's what we call type 2, reduced trophic factors, hormones, and nutrients, as I just mentioned. And then there's a type glycotoxic, very common, which we named type 1.5 because it has features of both. You get the inflammation part because you get glycated proteins. These are inflammatory as well as dysfunctional. And then you get the type 2 part, the atrophic part, because your brain no longer responds to insulin the way it should. And by the way, the A beta in your brain actually contributes to that. It was shown years ago that A beta itself blocks the insulin receptor. So again, it's part of changing the mode in your brain. The A beta is not there to give you a disease, it's there to protect you. But unfortunately, just as we saw in our country, the downsizing is part of that protection. Type 3 then, which is what that patient had that I showed you earlier, is toxic, inorganics, organics, and biotoxins, as I mentioned. Type 4, vascular, reduced cerebral blood flow. And this often gives you a mixed picture where you have some degree of vascular dementia as well as Alzheimer's. When I was training years ago, it was thought that people would either get Alzheimer's or vascular dementia. And we were taught to do something called a Hutchinski score so that you could tell which this was. Well, it turns out, guess what? Reduced vascular support is a critical part of Alzheimer's in many, many people. And then finally, type 5, and interestingly, traumatic. So there was a study done by Dr. Gareth Roberts in the 1980s showing that people who had automobile accidents with head trauma and then died within a week to 10 days had tremendous increases in their A beta. So again, it's a part of a response. Now, in many athletes, ultimately this will be cleared and you end up with the tau part, and that's called CTE, chronic traumatic encephalopathy. But with initial head injury, you get an amyloid response to this head injury. So because of all of these different things, this means that if you were going to develop the perfect drug, and we spent years in the lab developing drugs for Alzheimer's, the perfect drug would have to do this. This is the problem. This is too much to ask of a single drug, which is why we always tell the patients, think about it like a roof with 36 holes. You're going to have to patch the holes. And in fact, giving a drug is a fantastic patch for one hole. So as I said, 36 holes, because there are initially 36 causes that we found. We know of a few more now, as I mentioned. But you want to go after those, determine what they are, and then patch those holes. And then keep optimizing. That's what gets the best outcomes. And therefore, we have to train new kinds of physicians. And I know many people here are all already very well aware of this and are training in this. We really do need to change our view of how we evaluate and treat these complex chronic illnesses. So, of course, the traditional Chinese physicians, very good with treating the whole patient. They didn't know anything about DNA, RNAi, AI, large data sets, any of that stuff. The modern physicians, quite good with those, good with DNA, good with RNA, but don't typically treat the whole patient and look at all these. We really do have to change our view of medicine to network problems in complex organisms. And so, of course, we have to train a new kind of physician here that recognizes this and deals with all these different things. And so let me show you one outcome here. This is Edward. Actually, he was in the book that's called The First Survivors of Alzheimer's. One of the 7 people. He did absolutely beautifully. You can see here just dramatic changes, improvements in his scores. He's still doing very well. He started way back in 2013. By the way, the people who started first on this protocol were in 2012, and many still doing very, very well 10 years into this. Here's Marcy. As you can see here, she improved her hippocampal volume. She improved her cognitive scoring as well. She's doing very, very well. Here you can see gray matter volume in another patient went up by 23%. So just, again, remarkable improvements. I want to just take a couple of minutes to talk about the most common genetic risk factor. About two-thirds of all the people with Alzheimer's disease are ApoE4 positive. As I mentioned earlier, we have about 75 million Americans have it. So about a quarter of the population has it. But because they have an increased risk, it's about 2/3 of all patients with Alzheimer's disease. That had been known since the 1990s, but it's not clear why this happens. What's actually going on? You end up with Alzheimer's disease, but what's in the black box? Why does this happen? So we started a project in the laboratory over 10 years ago to look inside the black box. And what we found was really surprising. So it turns out this is an amazing gene. Some people would call this the God gene. It has to do with evolution. It has to do with shortgevity. People with ApoE4 tend to live a little shorter, and in fact, they shouldn't. Knowing it, getting on the appropriate prevention should allow them, in fact, to live longer. And Alzheimer's, it's the most common genetic risk factor for Alzheimer's. So here's what happened. When we look at the hominids that developed from the simians between 5 and 7 million years ago, what happened? There is actually a very small number of changes. And actually, my wife laughed at me, and she's an integrative physician, when I told her, my DNA is actually more similar overall to a male chimp DNA than it is to yours. And she said, well, duh, of course. You guys like the Three Stooges, you guys like ESPN, stuff like that. So, okay, that's true. So the bottom line here is, God comes down and touches us with DNA, makes the changes in the DNA, and we're over 95% similar to simian DNA in the hominid. So very small number of changes, but among those changes, prominently were things that have to do with inflammation. Very interesting, including ApoE. And ApoE4 was the primordial, was the original one. So you can see here what led to our evolution as hominids included ApoE4. ApoE4 is not present in chimps, but it is present in hominids. And here's what happened. So ApoE4, unlike the chimps, actually has this arginine 61, which was a threonine in the chimps. So it interacts here with glutamate 255. So positive charge here, negative charge here. So what happens is you get this molecule that looks like columns. And in fact, if you then have, here you can see here this, if you now, all for 96% of our evolution as hominids, we've all been ApoE44, the very thing that's associated with highest risk for Alzheimer's. Now, just in the last 220,000 years, last 4% of our evolution as hominids, with their subsequent mutation occurred. You can see here this cysteine 112. So cysteine 112 now interacts with arginine 61, and that allows this glutamate 255 to swing freely. So now it looks like a nutcracker instead of looking like columns. They look quite different and they function quite differently. ApoE4 is associated with inflammation and with Alzheimer's disease and with cardiovascular disease. ApoE3 is not. So as you can see here again, it's just been in the last 4% of our evolution as hominids that ApoE3 has appeared, and then just in the last 80,000 years, ApoE2. We don't know what supported this because ApoE3 is now the dominant one. It's the most common one. Some people argue this is when people began to use fire and cook. fire probably appeared before this, but perhaps it did have a role in allowing people to survive with something that is less pro-inflammatory. So as Professor Tunk Finch from USC has pointed out, and I think he's correct, what ApoE4 allowed us to do as a pro-inflammatory gene to come down out of the trees, to walk on the savanna, to puncture our feet, to get exposed to pathogens, to eat raw meat and things like that, and not to die from these various organisms. But it is a pro-inflammatory gene. So again, if you go to a place like the third world, you look at, for example, the Chimane Indians in Bolivia, they do better if they are ApoE4 positive. They do better with the parasites they're exposed to. And similarly, in some of the tribes in Africa, they do better, live longer, live healthier if they're ApoE4 positive. Now, why is it such a pro-inflammatory gene? This is what we discovered in the lab. It had already been known ApoE4 binds to a number of receptors, enters the cell, but what we found, interestingly, it interacts with REL-A, which is part of NF-kappa B. It's a pro-inflammatory intermediary. This complex then enters the nucleus, and interestingly, it binds to over 1,700 different promoters. And this is the work from Dr. Ramahan Rao in the laboratory. And so this gives us a new mechanism. It offers us a new look. This thing, ApoE, it carries lipids around, so it's thought to be like your butcher. It turns out also to be like your senator. It's giving you the laws of the land. It's affecting over 1,000 different genes, and it actually turns down these different genes that affect. So it's a transcriptional repressor, and surprisingly, it actually interacts directly with DNA. So it increases inflammation. What it does is it actually turns down several genes that are critical for modulating and bringing down inflammation, and therefore your inflammation goes higher, stays longer. It's also associated with SIRT1, the very reason that many of us take resveratrol, for example. So it actually turns down SIRT1. And you can look into brains of patients with Alzheimer's who die with Alzheimer's and are ApoE4 positive. Their SIRT1 levels are 60 to 80% lower. It is a striking effect. And then neurotrophins, alters microtubule disassembly, glucose homeostasis. If you look at these groups of genes, you couldn't tell a better story for Alzheimer's disease. So we published a number of papers on this. And as I mentioned, the trial that I'll show you in just a moment here is now posted on medRxiv. You can see that. We published a number of books describing these patients and also the first survivors, which was published last year. So I want to then talk for a few minutes about the trial that we did, because it really shows how many of these people can be improved. And again, earlier, better. Let's see how we're doing on time here. Okay. So first, let me say I'm really excited and honored to have done this trial with three outstanding functional medicine physicians, Dr. Anne Hathaway, Dr. Kat Toops, Dr. Deborah Gordon. They all did an absolutely fantastic job with these patients. So this is the first trial in which, instead of predetermining, in all these other trials, you say ahead of time, we're going to use this drug, or we're going to use this instrument, or we're going to do exercise, or whatever you're going to do, you predetermine what's going to be done for the patients. That actually makes no sense. We want to determine what to be done for the patients by determining what's causing their decline. And this trial was registered on clinicaltrials.gov, as all trials are. Interestingly, we tried to do a trial like this in 2011. We were turned down by 2 different IRBs. We tried to do it again in 2018. We were turned down again. The idea was, you're trying to do something that is a protocol instead of just a single drug or a single entity. And our argument was, well, yeah, this is not a single entity disease. You have to go after this with multiple different things. It was the 5th IRB that finally approved this in 2019. We completed it in December of 2020 and posted on medRxiv last May. And by the way, it's just been accepted for publication in a peer-reviewed journal. So small proof of concept trial with 25 patients. And these patients were beyond SCI. So these are people who had MoCA scores of 19 above, but all had to have MCI or early Alzheimer's disease. And we had some of them actually who went from MoCA scores of 19 all the way to 30 in the trial. So we were very excited about that. And the idea was we wanted to compare a personalized precision medicine type of protocol for over 9 months. Now, the typical protocol for Alzheimer's disease is done with huge numbers of people over 18 months. And why? Because the effect of the drugs is so tiny. You're not looking for an improvement. You're looking for, instead of doing this, you're doing this. It's slightly, so therefore slightly slower. So therefore, you've got to use huge numbers of people and go for a long time to find that statistically different. Because if you do that, you could potentially have a $500 billion drug. And this is unfortunate because this has really led to trying all these things that really don't work very well at all. In this case, we're seeing a bigger outcome. We're seeing a bigger improvement so that we can now actually look at smaller numbers of people for shorter times. Of course, we want to make sure with long-term follow-up that these people have stayed better. And we know from the anecdotes, we have people now decade on this that are doing very, very well because we're going after the things that are actually causing the problem. Then in the evaluations, we want to identify the root cause contributors, of course. We want to look at pathogens, all the things we've been talking about, toxins, metals, et cetera. We want to look at their genetics. We want to look at their nutrients, hormones, et cetera. We want to look at their immune status. The classic story with both COVID-19 and Alzheimer's is that you've got the innate system active and the adaptive system is not able to clear the problem. So in the trial, we assessed these people. We looked at their Montreal Cognitive Assessment score. So we will look at them at 0, 3 months, 6 months, 9 months. Now, for anyone who's used MoCAs in their practice, they're simple to do. You can do them in about 12 to 15 minutes. Great assessment for cognitive decline, but they're not terribly sensitive. The people who developed the MoCA developed it for looking at MCI. They weren't particularly interested in SCI at the time or people at risk. They were really focused on MCI. So therefore, we wanted to add a second test that was more sensitive to the MoCA so we can get a larger dynamic range here. And for that, we use CNS vital signs. It's a harder test. It's an online cognitive assessment. It looks at multiple different parameters from your executive function to your verbal memory to spatial memory and on and on. So they looked at 0, 3, 6, and 9 months there. That together gave us a larger dynamic range, and it excluded a ceiling effect. You can have a ceiling effect where someone would come in who really does have early MCI, but maybe scoring 28 on a MoCA, but their CNS vital signs will show very clearly that they are struggling to get that 28 on the MoCA. Then the third thing, which is very complementary to the first two, the AQ21 is where you ask the spouse or the partner to determine, and you ask them, have they had problem with memory? Have they had problem with forgetting this or putting things together or calculations or things like that? And the score on there goes from 0 to 27. And anything over 4 suggests that there's beginning to be some problems. If your partner is saying, yeah, this person's struggling with more than 3 different things, more than 3 different areas, then they're likely to be having problems. And so we took people with scores over 5, where the partner knew, yes, there's something that's a real problem here. Now, when you're starting to get up 15 and above, then this is compatible with full-on dementia. And we had some in there, but most of these people were in the MCI range. And then AQ20 is another score. It comes from the AQ21, but it's specifically for change. Did you get better in this? Did you get better in that? Or did you get worse? And so they score them from -2 to +2 for each of 20 different things. So you can have a score from -40 to +40, where you're looking at what does the partner think? Does the partner notice that you've improved? And we've included that because there have been some drug trials where there was a minimal effect, and so it was scored as, yeah, this is positive, but in fact, the partners couldn't notice anything. So we wanted to know, could we see objective changes, but could the person living with them also see subjective changes, so real world sorts of changes? And then finally, we did MRIs with volumetrics at the beginning and then again at the end. Did we make a structural difference? Now, of course, the problem with MRIs is that they're relatively insensitive to change. You can see improvements in electrophysiology, for example. which is more sensitive than what you'll see with actual structural changes of the brain. But we wanted to look nevertheless to see whether, in fact, we could see improvements. Now, the goals in these people then, we want to address the things that we talked about earlier. So we want to address their energetics. We want to get them into ketosis. If you happen to use a finger stick, we want to get them into 1 to 4 millimolar beta hydroxybutyrate. Doesn't have to be way up. If you're treating infantile seizures, people are getting it up 7, 8, very high. We need to get them at least into 1 to 4 millimolar beta hydroxybutyrate. If you like to use ACEs from a breathalyzer, we want to get you up above 7 and preferably even above 10. We want to make sure that your cerebral blood flow is adequate. So we want to make sure that your vasculature is working. We want to make sure, and that's again where getting people to do regular, relatively intense exercise can be very, very helpful. Oxygenation, one of the least appreciated contributors to cognitive decline. Many of these people, whether it's because they have sleep apnea or structural problems with their airways, are dropping their oxygenation. And many people, when they actually check that, are surprised by how poor their oxygenation is while they're sleeping. And then mitochondrial function, we want to optimize that. And as I mentioned earlier, substrates, ketones and glucose. Then we want to make these people insulin sensitive and metabolically flexible. We want to target their HOMA-IR to 1.0 or lower. Many of these people come in with HOMA-IRs of 1.8, 2, 2.5, or even 3. We want to get them down to 1.0. We want to give them appropriate trophic factor support, get their hormones to be optimized, their nutrients to be optimized. We want to resolve their inflammation. And again, some of these people will come in with a more of an atrophic approach and have no issues with inflammation. But others, inflammation is a common problem. And again, you have to remember the amyloid itself, the amyloid beta that's in the plaques in Alzheimer's disease, is a part of the innate immune system. So as long as your innate immune system's turned on, you're going to continue to make this. And this has been, as Professor Rudy Tanzi and Robert Moyer from Harvard showed years ago, A beta is an excellent antimicrobial peptide. Then we want to treat the pathogens and we want to optimize the microbiomes, whether it's because you've got pathogens intraorally, whether it's because you've got a tick-borne illness such as Borrelia, Babesia, Bartonella, Ehrlichia, any of these things, whether it's because you have a poor gut microbiome or a leaky gut, all of these things are potential contributors. And then we want to detoxify. Many of these people have toxins as part of the overall contribution to their cognitive decline. And then, no surprise, people who had some degree of stimulation, whether it was light stimulation, magnetic stimulation, brain training, these things are all helpful. So again, you have to think about it like someone working out with weights. The weights are the stimulation. You don't want to have someone on a regimen of weightlifting, but give them no nutrition. If they're sitting there with kwashiorkor or marasmus, they're not going to be doing well with working out with weights. We want to optimize all these other things, and then we want to stimulate them. We want to improve their adaptive immune system. So, of course, they should have appropriate zinc levels and magnesium levels and vitamin D and all these sorts of things. And we want to reduce the innate system because that's where the amyloid's coming from. And then after we do these things, we'd like to reduce the amyloid. Sure, that's fine. And actually, curcumin is one of the things that binds very tightly to amyloid and helps to reduce the amyloid level. And there are other things as well, but that's one way to get rid of them. This is where I think the drugs, these anti-amyloid drugs, are ultimately potentially going to be very powerful. Once you've addressed all these other things and you use them, you're going to want to go down on the dosages, use small amounts to help remove this, but you don't want to remove it as long as you've got these ongoing insults. And then ultimately, of course, regeneration and synaptogenesis. And of course, there are multiple ongoing trials for stem cells in Alzheimer's disease. But if you look at this, what you realize is that just doing stem cells as a monotherapy is like trying to rebuild a house as it's burning down. It really doesn't make any sense. We want to do the other things. We want to put out the fire first, then we want to rebuild. And I think they'll have an important role in rebuilding this. So lots and lots of data coming out of the trial, but I just want to show you one thing here and then give you a summary. So this is the CNS vital signs data. This is for the neurocognitive index, which is for all tests combined. You can see here that there are improvements from the baseline at 3 months, further improvement at 6 months, and further improvement at 9 months. Now, the pandemic happened right in here. So we didn't get lots of improvement at 9 months compared to 6 months, but in fact, it was slightly better. You can see here, a few people fell off the wagon here, stopped doing what they were supposed to be doing, and actually did a little worse at 9 months. But overall, as a group, there was still statistically significant improvement at each of the time points. So just to summarize then, 76% of these people improved their MoCA scores. Now, that's not saying they went down more slowly. They actually improved them, and the average improvement was 3.9 points on the MoCA scale. Their neurocognitive index improved. So 84% of the patients improved their neurocognitive index. And I see we're doing fine on time here. So cognitive subtests. Verbal memory was improved, statistically significant improvements. Executive function, statistically significant improvements. Same for psychomotor speed, same for cognitive flexibility, and others as well. Their AQ20s also improved. And so, in fact, their partners noticed that they had actually improved. Their brain HQ scores improved in all the patients. So their brain training. And perhaps most importantly, interestingly, if you look at the gray matter, so total gray matter in patients who have MCI or Alzheimer's, it goes down at about 2.5 to 4% per year. If you take someone who has no symptoms, just normal aging, it goes down at about 1.5% per year. So you still lose a little bit of gray matter each year as you're aging, even if you have no symptoms. These people actually, despite the fact that they had Alzheimer's or MCI, actually increased their gray matter volume over the 9 months. And we were quite excited to see this. This was done by Dr. Cyrus Raji, who's a neuroradiologist at WashU in St. Louis. And then finally, their hippocampal volume did decline slightly during this time, but interestingly, less decline than even normal controls and far less decline than someone who had Alzheimer's or MCI. So for all these different parameters, these people did quite well. And we're following them to see, follow-ups, we'll see how they do over a long period. But again, we know from the anecdotes that these people will stay. If they do the right thing, if they stay on the protocol, they will do very, very well. So the takeaways from all this, number one, cognitive decline is reversible for most patients with MCI or early dementia. And I should say that this sort of approach is much more like learning a surgical procedure than it is like writing a prescription. There are people who are really good at it, the people who are not so good at it. It takes a while to get good at it. We have training for anyone who's interested in learning about this, but you have to do different things to get people to get the best outcomes. And again, Dr. Hathaway, Dr. Toops, and Dr. Gordon did a spectacular job with getting these people on the right approach, and the health coaches, incredibly helpful. The nutritionists, very helpful. The physical trainers, very helpful. So for those whose cognition declines, we should look for contributors. They may be obvious. So the few people who didn't do well, it was fairly obvious what went wrong. And so, for example, we had one woman that was seen by Dr. Hathaway, turned out to have a lot of mold and mycotoxins in her home. She said, I'm not addressing this. I'm not moving out. I'm not remediating. And no surprise, she did not show improvement. So for most people, if you look, you can tell what's actually failing. Now, one critical piece is that the feasibility, getting this done, it's not simple. And so we want to make it easier and easier, of course, without losing the efficacy. So we're trying to simplify this, and also we're trying to do better with the computer algorithm to determine, can we tell people, okay, here's the thing that's far and away the number one for you. Here's number two, here's number three. Maybe just address a few of these and not do the whole thing. Of course, when we started out way back in 2012, we knew this was 100% terminal illness. So we were just going to do anything possible. And when people started to get better, we thought, wow, finally, okay, so we're getting over the hump here. I do think going forward, we may be able now to start telling people, here is your rate limiting step, and you only need to do a few things. We just don't know yet. So this provided strong support for a larger randomized controlled trial, and we're very excited to be doing this. The same 3 physicians plus 3 additional physicians, Dr. Nate Bergman, Dr. Craig Tanio, Dr. Christine Burke. So this will be at 6 different sites. And we're just in the late stages of designing this. We'll be starting in the next few months. And then could we use a similar approach here, modifying it for the pathophysiology of each of the major neurodegenerative diseases? I hope that's the case. They are driven by different things. Parkinson's is more of a complex one of the mitochondria, typically a toxin-related illness, sometimes infection-related illness. So it's a different sort of neural subsystem and a different Achilles heel than Alzheimer's. One is about neuroplasticity, the other one is about motor modulation. Each of these things have their drivers. And so macular degeneration, another example. So we actually have the first few patients on what we call the ARC project. This is just as the ARC was 2 by 2 by 2. We're looking for each of these people a deep dive into what's causing their problem. We have the first few people with macular degeneration that are in treatment right now. And then if you combine the fact that we can get improvements with the previous finding I mentioned earlier, there are decades before you have Alzheimer's disease. It really suggests that Alzheimer's disease should now be optional. I know that sounds crazy, but the reality is if everybody got on prevention or earliest reversals, we could make this the rare disease that it should be. So how do we make it optional? Everyone should get a cognoscopy if they're 45 years of age or older. And that's simple. It's some blood testing that I was talking about earlier. Basic blood tests. We want to know about inflammagens. We want to know about these various things that drive it. And then we want to have an online cognitive assessment like CNS vital signs, and you can do that. What we call the CQ test is a free online test. And then finally, if you have symptoms, you should also include an MRI with volumetrics. If you don't have symptoms, that's optional. If you develop symptoms, we want to go more evaluation. So the idea is to make this the most efficient. Everyone can do some basics, and then a few people will fall through the cracks. Those people want to have a more extensive evaluation, a more extensive approach, and then a few of those people will fall through, and so forth and so on. So if we have a multi-tiered approach, most people should do very, very well with just some basic prevention. We want to increase our sensitivity of cognitive assessment. The typical tools that have been used, things like MoCA and MMSE, these are picking up problems very, very late in the course. So we want to pick up problems much earlier. And as I mentioned, a multi-tiered system so that we can be more efficient. And then we want to use computer-based algorithms enhanced by AI. We recently looked at people who were just out there practicing this. And we do see improvements, not as great as we saw in the trial because these were physicians who were more experienced. But we want to now look at who did the best, who did the least, and can we pick up reasons for that? The usual reasons are compliance and identifying the critical drivers, and then severe toxicity starting late in the process. Those are the big ones. So the bottom line here is, just as for leprosy and polio, Alzheimer's is becoming a former scourge, and it shall become something that we don't worry about. My generation, this is the biggest concern as we age, is losing our minds. Our daughter's generation, they're now in their 30s, there's going to be the first generation not to fear Alzheimer's disease. So I think this is a very exciting time. We're making changes and seeing how we can get more and more people to prevent or reverse cognitive decline. So that's the real truth about health. Thank you very much. I'm going to stop sharing there. Happy to take some questions if you'd like. And again, thanks very much for the invitation.
Thank you so much, Dr. Bredesen. And that was really eye-opening for so many of us. And your work is game-changing. So thank you. And so that we are going to go ahead with our Q&A. What we do, just want to make sure everybody knows exactly where they can get your book. And if they want to reach you and have any questions, where can they go? Tell us more.
Yeah, so great point. First of all, we've published 3 books on this. You can get those from Random House. You can get them on Amazon. You can get them wherever books are sold. First one was really about the basics, what I was talking about today. How does this work? It's called The End of Alzheimer's. It's available in 32 languages. So if you want it in Spanish or Polish or Russian or Chinese or whatever, you can get that. Now, this summary, I did not write that, and I would remove that one because that is unfortunately a ripoff. They put my name on the front, and I actually asked an attorney whether that was allowed, and they said because they're saying they're summarizing your book, but actually I did not write that book, and there are all sorts of mistakes in it. So please beware of that. The one on the right here, End of Alzheimer's, came out in 2017. The second one here, the End of Alzheimer's Program, which is the blue and orange one there, came out in 2020. And that people asked for more practical details. You know, what websites do we use? Tell us more about the nutritional part. Tell us more about these various pieces. So I actually wrote that with a patient who has done very, very well, Julie G, who has done very, very well, who's an ApoE4 for herself. And then the third one, which came out last year, is the First Survivors of Alzheimer's. And so I updated the protocol on that one. Now, you can also get information online. You can get on Facebook. We have Facebook Lives every 2 weeks. So Facebook is Dr. Dale Bredesen, and we're on Twitter, of course, and Instagram as well. And then you can go to Apollo Health Co. We have training. So Recode is the name of this, Reversal of Cognitive Decline. Recode 2.0 training. We've trained over 2,000 physicians from 10 different countries and all over the United States. And we're always excited about having people who have learned this because we can now refer people to them and get fantastic results. Like, you know, you'll see that when you start getting emails from people or when you start talking to people who come into the office and who have actually improved, it's so wonderful to see because this has been nothing but, unfortunately, but an illness that has been 100% fatal. A couple of the physicians have told me when their first patient came in with improvement, the physician cried, not just the patient. So it's wonderful to see this. And again, the more we can all encourage people to understand the future, to get in as early as possible, to get all the family on active prevention, the more we can all impact cognitive decline and reduce the global burden of dementia. Which is such a critical issue. This is a $1 trillion global problem that disrupts families. And as I said, there's going to be something like 30 people who are here today who will die of Alzheimer's. Let's make that 0. Let's see if we can make it 0.
Thank you for that. And thank you for being a stand for all of us. And with that, I know we have some questions. So thank you for doing this Q&A with us.
Sure.
Just want to make sure everybody knows how we go about it here at the Real Truth About Health conference. And that is that we normally don't take questions directly from the chat box, but instead we ask everyone to virtually raise their hand. If you're not sure how to do that, you can go down to the bottom of your Zoom window and you'll see a tab that says reactions. You go ahead and click on your reactions tab and then click on the raise hand function in that menu that pops up. We'll then take the raised hand questions in the order in which we receive them. Again, I see some that have already come up on the screen. And so when it's your turn, I'll go ahead and call on you by name. I will unmute you and you'll be able to ask your question directly for Dr. Bredesen. So with that, set to go, Dr. Bredesen?
All set. Thank you.
Appreciate it. Thank you. So our first question is going to be Debbie S. I am unmuting you now. Hi, Debbie.
Hi, how are you? Thank you, Dr. Bredesen. I actually went and saw, was it Dr. Ross? Someone that worked with you.
Yep.
Originally. So
Right.
I have ApoE4. My father died of Alzheimer's. Okay. I am a low sugar plant-based eater for like 10 years. I have no problems with insulin resistance. So when I look at the list of the different types of Alzheimer's, like what's the mechanism? What could happen to me if I'm keeping if I'm keeping all my numbers favorable?
Yeah, so your home IR is good, I'm assuming. And so where do you stand with your metabolic flexibility? Are you getting into ketosis?
No, I tried that and I didn't feel well. So I ended up stopping.
Okay, now,
Is
so
that
what
something
you-
now? I don't have any signs of MCI or even CSI.
No.
Should I still try to do that so I can switch?
It's a great point. Well, so you know ahead of time, that's great. And what's your current age? If you don't mind my
60
asking.
No, 63. 63.
Yeah, perfect. So yeah, you're a youngster. I'm just ready. I'm just turning 70. So yeah, so you're a youngster. So that's great. And this is perfect. So you are the perfect person here, having insulin sensitivity. You've got a single copy of ApoE4, as you know. It's, you know, you have a family history. So you want to keep yourself on the right side. Now, what does that mean? It means making sure that you don't have ongoing inflammation. Do you know your HSCRP?
Oh, sorry. No, I just know everything's normal.
Yeah,
HR,
okay.
HRCRP.
HSCRP. So you want to make sure your high sensitivity C-reactive protein is down substantially. We'd like to see it down below 0.9 or down more like 0.3, 0.4, not up at 1.1, 1.5. Again, you have to remember you have ApoE4, which is a pro-inflammatory gene. So you're very good at responding to inflammagens and responding to pathogens better than many people, but it puts you at the same time at risk for having chronic ongoing inflammation. Do you know the status of your gut? Do you have any leaky gut?
No.
Okay, that's great. So you want to, so the things that you could give you problems are energetics. You want to make sure that you have appropriate cerebral blood flow. Do you know your nocturnal oximetry? Is it possible that your oxygenation is dropping down at night?
I don't know that.
Okay, so that's another critical. So the bottom line here is you have to be aware of, and this is where, you know, working with a health coach or working with your physician. What part of the country are you in? Are you in Northwest or are you in
South
Southeast?
Florida. South Florida.
Okay, fantastic. So there are all sorts of physicians all over Florida that do this protocol. And there are health coaches as well. So you want to work with someone, and it sounds like you worked with Dr. Ross in the past. So she would have certainly checked this. Do you have a recode report? So we actually have a report that goes through all these different things that is generated. And if you have that, it'll show you, and I'm happy to go over those as well. It will show you all the different things that are contributing. So in your case, yes, you need to be concerned about anything that's inflammatory. Your oral microbiome. Do you have any, chronic sinusitis issues? Do you have any tick-borne illness? Florida is a common place for mold exposure. Do you have a high burden of biotoxins? How are your heavy metals? Do you have issues with mercury amalgams? That's another common one. Do you have reduction in your estradiol, in your progesterone, pregnenolone, thyroid, things like that? How's your vitamin D status? Then getting the energetics. So the big four that I mentioned before: energetics, trophic, making sure that you don't have too much inflammation or too much toxicity. Those are the big four contributors. And clearly you've addressed some of them already. Now, you brought up a great point. Do you need to get into ketosis? And this is actually a point of contention. So we're still arguing about this with the various practitioners. If you have symptoms or you're scoring poorly on the testing, cognitive testing, you absolutely want to add ketones to the mix. And you can start out with exogenous ketosis. You can do things like, ketone salts, ketone esters, or MCT oil. And again, work of Stephen Kinane, very interesting in this area. This is critical for supporting your brain. However, we recognize at the same time, people who are taking MCT oil can increase their LDL particle number. So if you've got vascular issues, you want to think more in terms of ketone salts or esters, which don't raise your LDL particle number. On the other hand, you pointed out you're just interested in prevention. Now, again, if you develop symptoms, you want to go on reversal, but this is great because you'll catch it early. Prevention only, you don't necessarily need to get into ketosis, but you do want to be insulin sensitive. But if you find, because there are changes with people with ApoE4, you can get changes even into your 20s in terms of changes in the PET scan. So if you do find there are issues with cognition, please make sure that you add the getting into ketosis so that you can now go back and forth between ketones and glucose. And if you've got, do you remember what your HOMA-IR was?
We've lost her.
Okay. But in any case, so the idea is, yes, there are all these different things that can contribute, and especially for people who are ApoE4 positive, nobody should get this problem. Be aware of those, work with a health coach or work with a practitioner, and make sure that you don't slip into cognitive decline. If you begin to have it, don't chalk it up to just natural aging. Get in, get treated, make sure that you address this as early as possible.
Thank you so much for this, Doctor. It really means so much to so many of us. I'm going to move forward now to Alex. Alex, I'm going to go ahead and unmute you. Hi, Alex.
Hello. I am sorry, I am from Germany, and I am suffering from severe chronic fatigue syndrome, myalgic encephalomyelitis. I'm right now in my second major crash in 12 years. I have started with raw food in 2011, and it helped me pretty fast to go again, be able walking and so on. And I even managed to study again. I'm 59 now. So in my early 50s, I had a cognitive decline test saying like the first run was 30 points, very normal, but 5 minutes later, it was only 16. 16. And I mean, I don't sleep very much, so I cannot. And now this time when I crashed because of the stress of pandemia, etc., it was just my symptom. My system couldn't take it. I went back to total raw food before I had swifted Dr. Joel Fuhrman diet and such stuff. I went back to complete raw protocol, but it did not help. Really, I was kind of shocked. And also, I have to say, I find myself now more mentally impaired. Like back then, I could, after 2 years in my major crash, I was already further back to reading. Like when I was 7, I was reading 5 books per week from that time on, like news magazine and so on. So reading is my little finger capacity. And all this is really declining. Like I can read 2 to 5 pages per day, which asks high focus. So I'm worried, and I wonder how could I help or be helped?
So thank you for mentioning. Thank you for asking. So this is, again, you are a perfect example of exactly what we talked about today. So you have a process that has some ongoing inflammatory process. Your brain is responding to that. And as you said, you mentioned here in your note that it's like long COVID. Absolutely. You have what started really as brain fog, but from what you're saying, it's really progressed far beyond typical brain fog. And when you said 16, are you talking about an MMSE or a MoCA score, or which sort of score? Because if it's 16 out of 30, that is relatively far along, just as you've said. So we need to now, you did part. You went to some raw food. That's all fine. But remember, that's helping you to respond better, but it's not taking away what's actually causing it. So the question is, have you been evaluated for chronic inflammatory things like various herpes viruses, a relatively common cause to cognitive decline? Exposure to mold and mycotoxins, a relatively common cause of cognitive decline. Other chronic illnesses, tick-borne illnesses, things like that. Do you have leaky gut? So something is still affecting you, so that when you try to start some treatment, which is fine, you did that right, there's still an ongoing problem. As long as you've got that ongoing problem, it's going to be very hard to turn around. Now, you mentioned that you're in Germany. Is that correct?
Exactly.
Okay. So you have one big advantage. Germany is the home of the IGL test. And I don't know, have you had the IGL test?
I don't think so. It doesn't, I'm not familiar with the.
So a group in Germany, check out IGL.
Yes.
A group in, we're starting to use that here, and groups in the US are starting to use it. It's a really interesting test. And it has combined epigenetics with studies of mitochondrial function and toxicity, and looking for what's actually driving the problem for each person. So, and I think, you're a perfect example, perfect, case for where someone could potentially find out. So this will help tell you what is actually driving this. Are there specific toxins? One of the things they look at is, are there toxins actually bound to your DNA that are impacting you? And you have to say I was skeptical when I first heard about this test because it sounded a little hokey. But I've talked to the group there. It is a pretty interesting test, and one of the physicians in the U.S. has been using it extensively and getting some very good results with it. So you have the great good fortune of being right there in the home country. And then I would link with someone who has been trained in reversal of cognitive decline and to address the thing, because it sounds like what's happened and happens to many people. You've begun the process, but you haven't identified what's actually causing the problem. So you haven't gotten your best outcome. And unfortunately, you're not on the right side of that curve yet. So you're still declining. We've got to address more of the features here. So understanding them, identifying them, and then addressing those, whether it's because you have ongoing viral infections, tick-borne illness, mycotoxins, leaky gut, or it's an oral microbiome issue. You need to know your oximetry. Are you dropping your SpO2 at night? That's another critical determinant. Unfortunately, human beings are complicated. And there are many reasons that our brains can fail to provide the normal service. And that's exactly what you're describing here. So let's find out. And again, the IGL test can be helpful to you.
Thank you so much for that, Doctor. We're going to move on now to Annette. Annette, I am going to unmute you. There you are. Hi, Annette.
Hi, how are you?
Great. Welcome.
Thank you. Hi, Dr. Bredesen. I'm 65 years old, and I'm having trouble with coming up with words and remembering things such as the ending of a movie or the sequence of a plot. And my mom died from Alzheimer's when she was 77, and her brother was diagnosed at age 52, and he died 16 years later. And I don't know where I stand on any of the tests that you mentioned and don't know where to go to get the test. And how can I find a doctor here in Las Vegas who uses your protocol?
Yeah, that's a great point. And so the easy thing, you can just go to drbredesen.com. And you can look up their doctors. So again, we've trained people all over the country. I'm trying to remember, over 2,000. So I have to say, I know the doctors in certain areas, and I'm trying to remember Las Vegas. I don't remember, I apologize for that, who is actually in that area, but we can certainly get that for you. So if you go on drbredesen.com, or you can go on Apollo Health Co. We work with Apollo Health because this is a group from Silicon Valley that does large data sets. And the whole idea is that we as physicians have unfortunately spent over 1,000 years looking at these tiny data sets. We need to know more. We need to know what are all the contributors to your cognitive changes. I think we know what you're describing, if it becomes severe, would be what we would call primary progressive aphasia, which is commonly due to Alzheimer's disease. But a little word finding at the beginning, that's a very common thing. And that doesn't necessarily mean that you have primary progressive aphasia. But you've got the family history that you mentioned. You've got some very typical symptoms. I don't know, have you done any cognitive tests?
Well, the doctor did the MoCA test and I was fine, she said, but she didn't give me a score. And then she doesn't want me, she said I could go to a neurologist for the genetics test, but she didn't recommend I get it because she said it's better not to know.
I know, isn't that amazing?
Yeah.
It's better to stick your head in the sand and not do anything and let yourself go. I mean, it's just sad. And unfortunately, that's what many people say. But the reality is, it is important to know, because then you have a pro-inflammatory gene and you have to focus and do things a little differently. Please check out apoe4.info, wonderful website, free to set up by Julie G, who is at ApoE44, who's done beautifully. She went from 35th percentile to 98th percentile. She wrote part of that second book that I mentioned. She's amazing. And continues, to treat herself. She's now 10 years into this and doing very, very well. So it's actually helpful to know. And it's not just about going to a neurologist. Most neurologists are going to write you a prescription and tell you there's nothing to be done. So from what you're saying, the doctor may tell you have SCI, subjective cognitive impairment, since you scored well, or may say, well, if you take a more sensitive test, you really are into early phases of mild cognitive impairment. But those are good. Either of those things it means you're in a good prognostic group. You should come out of this being perfect. So you want to get with someone who understands this sort of approach, who's going to check these other things. Now, and I should mention, a lot of people say, well, gee, you know, I don't want to pay for testing. Okay, so there are some, you can get some things paid for by insurance, but it is true, because this is relatively new, a lot of insurance won't pay for some of these tests. Now, why do we recommend doing them? Well, the average person who develops Alzheimer's spends by death $350,000. It's horrible. A lot of this on nursing homes. So if you spend, you know, less than a tenth of this, you will, over time, you will be able to stay out of a nursing home, keep yourself in great shape, hopefully return to normal. So yes, the test may cost you several $100s, something like that. But it's, you know, again, in the long run, it's really worth it to get the test, to know where you stand, and to stay out of the nursing home.
Fantastic, doctor. Thank you so much. Up next, we have Wendy. I'm going to unmute you. Let me give that one more shot. Hi, Wendy.
Hi. Thank you so much for all the great information. I kind of have a two question, if you don't mind. My first one is, my dad was diagnosed with vascular dementia earlier last year after MCI, and it seems like most talks I go to and everything are all about Alzheimer's. Is there a similar path with vascular dementia? Are there other things to check on and do?
It's a great point. So each of these things has different contributors, and we've talked about, you know, for Alzheimer's, and Alzheimer's often has a vascular component. So unless they actually look to see with a PET scan or spinal fluid, they won't know if his vascular dementia also had some Alzheimer's. Very possible with an ApoE4, he probably did have both. And so you want to, again, understand the things that are driving this. Now, for vascular dementia, absolutely. First of all, do you know your triglyceride to HDL ratio? And do you know your LDL particle number?
No.
Okay, so these are critical. You want to know what's the status of your vascular tree. And the good news is, what you want to do, again, imagine this, your brain is begging for support, right? And vascular support is part of that. And so your vascular tree, if it is compromised, you want to increase blood flow. Well, great, you can do that with things like EWAT. So exercise with oxygen therapy, very helpful. You can do that with high intensity interval training, very helpful for getting that blood flow. Then you can get the substrates there with some ketosis. You can get the oxygenation there. Has anyone checked your nocturnal oximetry to see if your oxygen is dropping at night?
Mine actually is, and I started CPAP in November.
Okay.
And I don't know how accurate this is, but so my doctor sounded like that was going to take care of it. But I recently got like a Garmin watch, and it shows it low like all night long.
Well, yeah.
I don't know if those are accurate or not.
Yeah, no, well, I mean, if it's showing it all night long, it's a concern. So again, optimizing these different parameters. What we call Alzheimer's disease is essentially an insufficiency. It is a network insufficiency. So it's a little bit like having a struggling company. Lots of things wrong. We got to pick all the different things, and we got to improve each thing. And so you've already clearly indicated, oxygenation is an issue here. Blood flow may be an issue. The genetics with the ApoE4 is an issue. So you've got some very clear things to address here. And absolutely, vascular dementia is approachable with these things. There's another thing. Have you ever seen these restriction bands, so-called KATSU bands? And people in the Olympics were using these things. They basically give you more bang for your buck with your exercise. And you can buy these are restriction bands you can buy for about $35 or so. And so pretty easy to buy, pretty easy to use. And again, supporting your improvements, supporting your blood flow. So, again, you're a perfect person to get a cognoscopy, determine what's actually driving the problem, and then address those things. Absolutely.
Thank you very, very much for all of this, Doctor. And you're really being very gracious with all of your answers. We all appreciate it. We've got a few more questions, a few more minutes, if that's okay. We'll Move on to Suzanne R. Suzanne, I am unmuting you now. Hi, Suzanne.
Hi, how are you?
Great. Welcome.
Okay, can you hear me?
We can. Thank you. What's your question?
Hey,
For
Suzanne.
All right. I don't think I have the Alzheimer's gene, though I do. My father had Alzheimer's.
Mhm.
But for 25 years, I've had breast cancer and treated it mostly with raw foods diet. And in the last few years, really struggled with inflammation due to introducing wheat back into my diet.
Yeah.
But I am on, the only drug I'm on is a Remedex, an estrogen blocker, and that's always concerned me. Nobody addresses that. How does that affect my brain? I'm age 76.
Yep, it's a great point. My wife had breast cancer 25 years ago as well, and she's done very, very well. She was also, same sort of story on prevention for the first about a year, and then she decided to get off that and has done similar things to you, trying to address the various potential concerns. And yes, you're right. People who have ongoing inflammation, that is a concern. And again, find out the things you mentioned. Introducing wheat, definitely that's a common one. There are other grains and dairy, as you know. Are you on an anti-inflammatory diet?
Most of the time I am. I've had some struggles with it recently.
Exactly. And then as far as Arimidex, this is definitely can be an issue, because you have to remember the things that support your brain, the blood flow, the oxygenation, the mitochondrial function, the ketones, the glucose. Among those are the support, hormonal support. So anytime that you are messing with that hormonal support and reducing the support is a potential problem. And so the good news is it's one of many. So you can typically get away with sticking with that, but now doing all the other things correctly. Do you know your vitamin D? Do you know your HOMA-IR? Do you know your LDL particle number? Do you know your SPO? All these sorts of things are critical. Again, you have to remember this whole system works together. And so, yes, you can often affect one thing and still do very, very well overall by addressing all the other things. And obviously, you've already started to do that by looking at when you've got inflammation. So I would optimize the other things. And you mentioned the ApoE, the Alzheimer gene. Well, there's not just one gene. There are over 30 different genes, but we talk about ApoE4 because it's the most common contributor. But there are other things, and we see, for example, people who have poor detox systems will often develop cognitive decline, irrespective of ApoE4, because they have poor detox. And so there are different reasons. Dr. Sharon Hausman-Cohen has developed Intellex DNA, which is one good way to go. And she looks at detox systems, and she looks at all the different functional medicine things associated with cognitive decline. I think she's really done a nice job with looking at all these different things so that you can then target these different things. And again, getting with someone who would be helpful to you with prevention of cognitive decline would be another important thing to do. So again, the fact that you're addressing these things early instead of very late is really a smart thing to do.
Excellent, doctor. Thank you very, very much for this. Up next, we have Gwendolyn. I'm going to go ahead and unmute you. Hi, Gwendolyn.
Hello.
Hi, welcome. What's your question for Dr. Bredesen?
I'm speaking for Gwendolyn. You mentioned something about an online cognitive test.
Yes.
Can you say what that was again, please?
Sure. Yeah. And by the way, there are different ones as well. The one that we typically use is called C, like cold, CQ. And if you look up CQ test from Apollo, APOLLO, you'll see though there's a free CQ test that will give you an idea. Where do I stand with my cognition? How are things going? And it's relatively sensitive, so you can begin to see changes. Sometimes people are surprised, like, okay. The things aren't quite as perfect as I thought they were. And, this has been one of the issues. We all come in, there's the old joke about the guy and his wife, and he said, I think you're what I think that you're not doing as well with your memory, and I'm going to give you a memory test. Can you go into the kitchen and can you make some eggs and some hash browns and some sausage and some coffee and come back? She says, no problem. She goes in and she's banging around. She comes out 15 minutes later and she's got ice cream with some hot fudge on it. And he looks at her and he said, hey, you forgot the cherry. And so, he doesn't have a good memory. She doesn't have a good memory. And so many of us just live with that as we get a little older and don't realize it. In fact, there's so much we can do about that.
Thank you, Doctor, very, very much. Looks like at the moment we've got one more question, and this is from Ruth L. Ruth, I'm going to go ahead and unmute you. Welcome, Ruth.
Oh, thank you. Hi, Dr. Bredesen. I'm in Canada, in Toronto. Is there anybody here that you know of who handles these matters regarding?
This is a great point. And so, yes, we've had trained people in this approach, and there are some people in Canada. Now, to be fair, so our goal is best outcomes. There's Dr. Knipping, Knipping, who took our training. Now he's kind of decided he's trying to do things a little differently, so you may or may not be like the way he's doing them. But he's certainly one who has trained in this area, who is in the Toronto area. The other way, again, is to go on, just go on the website, Apollo Health Co. And look, and they can, they can see, or even, contact them and just say who's in the Toronto area, and we can give you others as well. But yes, there are a number of people in Canada. Dr. Vieg, who's way out in Vancouver, but he's doing fantastic work there. And there are others as well.
Thank you so much for that. We have actually one more question coming back in. I think Annette is back. If that's the same Annette, let me go ahead and unmute you. Hi, Annette.
Hi, I just have a quick question. I went on your website and the only providers I could find it within Las Vegas, within 50 miles, were 2 chiropractors. Would a chiropractor be able to do anything?
This is a great point. So we've had people who've trained who are neuropsychologists, who are nurse practitioners, who are chiropractors, who are neurologists, who are endocrinologists, health coaches, on and on and on and on and on. So the fact that someone's a chiropractor doesn't necessarily mean that they don't know this. I would check them. And the thing that I think is always easiest, find out how many people have they improved. And is this something that they're able to do? So we have chiropractors who are doing this very successfully and chiropractors who are doing this less successfully. And so I'm sorry that that's all you could find in that area. But I would check with their office and ask, do you have people that have improved? What tests can you do? And then see. And then the other possibility, there are some doctors getting fantastic results. For example, in San Diego, Dr. Heather Sanderson and Dr. Wes Youngberg, 2 people in San Diego that are getting absolutely spectacular results. So you're not terribly far away from San Diego. That's something to think about. Also, Palm Springs, Dr. Jocelyn Brosfield getting excellent results. So something else to think about. So there are different people besides just those. And maybe you want, because you can do a telehealth after the first visit. Typically, you might want to start by taking a little vacation for a day or 2, and get evaluated by one of those doctors.
Thank you very, very much for that, Dr. Bredesen. As it turns out, we've got one more question in from David A. I'm going to unmute him. Hang on one second.
Can you hear me?
We can hear you now, David.
Okay, great. Thank you so much.
Yeah.
My first question is the heavy metals. Would you recommend zeolites or oral chelation or IV chelation, or it just depends on the heavy metal? And should you get rid of parasites first before you do either getting rid of heavy metals or any kind of pathogens like Lyme disease? Is there a certain order to which you should address these issues?
Yeah, this comes up all the time. So first of all, as far as which heavy metals and what to do, it really depends on how much you have, which ones they are, and where your cognition is. In general, And we heard this in the previous talk. Go slowly. This is not a sprint. This is a marathon. We want to slowly improve things. And people often will have a combination. They'll often have some heavy metals. The biggest one we worry about with cognitive decline is mercury. Mercury is the one that you can literally inject mercury into a brain in an animal and get Alzheimer type changes. It is associated with both the plaques and the tangles of Alzheimer's, and relatively common contributor. However, the others can contribute, especially because they take away your detox. So things like lead and cadmium and arsenic and things like that can be secondary contributors. And of course, there's been the association with aluminum for years. That's been controversial, and that's still, the jury's really still out on that, but there's certainly an epidemiological association. Now, as far as parasites, it depends on which ones. It depends on how you present. So people who present with more of that biotoxin-like illness, I would certainly want to deal with the parasites. But also, you don't want to leave the metals high, and you want to be able to gently. I kind of like more gentle approaches. If you really get into the heavy chelation, again, just as we heard before, this starts moving things out. And once you have to remember, it's not perfect. When you're moving these toxins out of organs, for example, you're not ferrying them out perfectly. Some of it's dropping off in your blood. So you can create ongoing toxicity by being too exuberant with trying to detox. So take it slowly, keep on going, keep removing it. And you want to change that balance from I'm accumulating them to I'm detoxing. Now, interestingly, when we first looked at these people, we were so surprised. So many people are presenting right around the time of perimenopause and menopause, or andropause. And it turns out that so many are presenting with a toxin-associated illness. And it looks like what's happening is, when you're young, you're storing, you're trying to do everything. You're detoxing, you're eliminating, you're metabolizing, but you're also storing these in your bones and storing them in other organs. Now, as you get a little older, you go through this so-called osteoclastic burst for several years, where you're now emptying these things back in as your bones are changing into your bloodstream. And so you're now seeing people who have this presentation with toxicity. So again, it depends on what the metals are, or what the pathogens are, how extensive these are, your overall presentation, and how you do. Some people really like to do more on the cube. Some people, for the ones who are pretty toxic, I loved at the beginning some intravenous glutathione. Other people like intranasal glutathione. I'm careful typically with the chelators, because you can be kind of too exuberant with that. So be careful about that. And again, go to someone who is very experienced with detox.
Dr. Bredesen, thank you. That's all the time we have for our questions now. We're going to be heading into our next lecture shortly. And I just, what you're doing for all of us is heroic, and to have a pioneer like yourself come here and be with us, and you're back here for yet another year. And we just so appreciate you coming back and sharing this with all of us. And the thing is I'm not the only one, I think, that wants to thank you. So I'm going to have our tech team go ahead and unmute our entire audience. Everybody, what do you want to say to Dr.?
Hey, thank you so much.
Dr.
Bredesen, God bless.
Yes, thank you very much.
Thank you.
Away if you know how to